Our next speaker, I suspect, doesn't need much of an introduction, as he's well known to most of us here, Michael Hayden. Dr. Hayden is the Killam Professor of Medical Genetics at University of British Columbia and a Canada Research Chair in Human Genetics and Molecular Medicine. He's also the Director of the Centre of Molecular Medicine and Therapeutics and co-leader of the Canadian Pharmacogenetics Network for Drug Safety, a BC-led Genome Canada-funded national strategy to prevent adverse drug reactions. In his spare time, he starts biotech companies. Author of over 700 peer-reviewed publications, Michael focuses his work primarily on genetic diseases, including the genetics of lipoprotein disorders, Huntington's disease, and predictive and personalized medicine. Michael and his group have focused on identification of genetic variation influencing drug response in patients and has been working on developing personalized medicine to incorporate these findings so as to optimize drug therapy for patients. Of note, Michael is the most cited author in the world for cholesterol transporters and Huntington's disease. He's been the recipient of so many awards, 6 alone in this past year. He's received the Canada Gardner-Whiteman Award as a physician scientist and an Order of Canada. Today, his talk is entitled Personalized Medicine, Hyper and Hope. We're looking forward to it.
No, that's not mine, although I could give David's perhaps again, just same slides, different talk.
Is it this one?
Actually, can't see. Yeah, that's it. Thank you. Very good. Okay, well, thank you, Kathy, and it's been a fabulous day. What a wonderful perspective, and I think a wonderful opportunity to hear some discordant views on a topic that I think is going to have big impact for all of us. And I think probably I'm going to add to that now and share with you a little bit of my own perspective on where we're going, where we are, and then apply this to pharmacogenomics, and in particular, its relationship to what we've been doing in Canada and what we've been learning. So I would say, as scientists, have been part of the problem. And part of the problem has been that when the human genome was announced, 2000, and then the sequence came out, a lot of the hype and hope that was promulgated after that particular time was because people believed what we said. Francis Collins, a beloved person for all of us, but in fact said by 2010, genetic variants will be part of personalized care and be given by family physicians throughout North America. Clearly that we haven't reached that particular milestone. And many hypes around a lot of the way we've spoken about some of our own findings for DNA variants, be they for neurodegenerative disorder and other disorders like diabetes, confusing DNA association, DNA variants, which alter an odds ratio somewhat, often statistically significantly, but not really providing really meaningful and clinical data. So the statistics are really like bikinis in a sense. They're important for what they reveal, but more important for what they hide. And essentially, many of these association studies that we've seen around DNA variants have really essentially overstated some of the impact, and we've been part of that problem. So I would say that the challenges have been, so how do I go forward? Okay. And of course, this has been taken up in the community in all kinds of ways, with DNA becoming an icon of our community, you know, between the DNA lounge and using DNA perfume that you can smell beautiful forever, awaken the power of your genes, the elixir of life. Even the Dermatology Nurses Association changed their abbreviation to DNA. So this has been everywhere. And I would say what we have learned, of course, is how different we all are, and how specifically different we are. And another of the major challenges in terms of understanding these differences is, in fact, that many physicians who are about to have, and the number of 25%, we did the same survey in British Columbia, and 30% of family physicians in British Columbia have been asked to interpret, they've had 30% said they've at least one instance where they've been asked to interpret a result, a DNA test, of somebody who's come into their office. So it's not 30% of the population, but 30% of them have really been faced with this. And this is the problem. They're older, they look like me, they have little hair, they didn't even have any genetic training at all, and the challenge and the problem right now is, in fact, that even genetics in certainly our medical schools in Canada is poorly taught. Genetic medicine is not part of the curriculum. It's very hard to get it part of the curriculum. And in Vancouver, in fact, at UBC, the amount of genetics and genetic medicine that the students are learning is remarkably small. So this is a real problem because the people being faced with this information are poorly educated, and there's actually no plans to really try and increase the number of translators of this information, who in the end will not be able to be physicians, but will need to be genetic counselors, nurses, social workers, all kinds of people who will act as the intermediaries and the explainers. And this is part of the other problem. How do I get it to go forward? Do I maybe just do this? Yeah, okay. This is the part of the other problem, and that is that when we look at increasing risk, and there have been many, many studies for many common diseases, from diabetes to Alzheimer's to atherosclerosis, the problem is the odds ratios for many of these studies essentially are in the ones, 1.2, 1.3, very interesting scientifically. And when they're reported, these are the kind of things that happen. People say that the prevalence, the odds ratio is 1.18, for example. This is the mean for many of the diabetic studies that have been done over the last 10 years. This means there's up to a 20% increase in risk. That is true for those individuals. But in fact, what happens is your risk has gone up from 4% to 4.7. What does that mean for the patient in terms of interpreting that particular data? And this is, again, part of the problem that you can talk about a 20% increase in risk, which sounds dramatic, but in fact, we're still better telling our patients to exercise, eat less fat, eat less sugar, and do various things as opposed to get involved with some of this. So part of the hype, and over the last 2 years, there have been many editorials and many commentaries that have said that, in fact, the genetic revolution hasn't delivered on the promise, and hasn't delivered on what we actually promised about 10 years ago. So we've said your life is in your hands, and that's true, but much of this has been lost in the translation of these particular results. And the translation, of course, and you've heard today about the incredible errors in the actually the number of errors in the DNA sequencing, the interpretation of whether a DNA variant, even if it's conserved down to, C. elegans or even down to the pufferfish, even when that residue is conserved, that doesn't always mean that it's functional. There's an absence of translators. And then there are real problems in terms of how in Canada, and really in the United States as well, of course, reimbursement will work for providing these services. And right now, these are all really fundamental barriers that really would say that a lot of what we have, despite all of these incredible advances, a lot of this has been hyped. Now, just in next week's Science, or maybe the week after, we've written a perspective on this, opposed to somebody from Complete Genomics who is saying that everybody should get their whole genome sequenced immediately and only analyze certain amounts. I'll just draw your attention to that. And we're saying that there are many breaks that are needed in the system and many issues that need to be addressed prior to being ready for wholesale whole genome sequencing. And of course, the other issue is that it's not all about genetics. The environment is critical. We now know that DNA sequence is only one variant, and one aspect of variation that's very important, but epigenetics is critical, and the studies, for example, of identical twins who become divergent in terms of clinical phenotype, and that discordance is really a clue to epigenetic changes and the beautiful interplay and the resolution of some of the incredible nature-nurture discoveries and conflicts is really now epigenetics has really helped us to understand about how maternal care, for example, affects the epigenome of offspring. We've seen in many other aspects, nutrition of mother affecting the epigenome of the child with some later onset diseases such as cardiovascular disease and diabetes in the Netherlands and so on. So there are many factors and many issues that really need to be addressed before we are ready. We've heard some beautiful work around cancer today, and just trying to go forward. So we're stuck. But so I'm going to now focus for the rest of my talk, oh, there we go, on, in fact, where I see there is tremendous hope. And I think the stories you've heard, I'm not going to touch on cancer, but the new anatomy of cancer and the new approaches to therapy and potential stratification, particularly in the cancer field, and the opportunity to find mutations that, in fact, and within patients in certain tissues, the context of what David was talking about are so important, represents, I think, going to be the place at which personalized medicine will, in fact, reach some of its goals and hopes and aspirations firstly. But this is the area where I also believe that there is tremendous opportunities, and I'm going to give you a few examples today and tell you what we are doing in British Columbia right now around adverse events in an effort to really fulfill some of the promise. Now, I think everybody knows here about how frequent these are, how this is a major chronic problem. Most admissions, 7% of all admissions are having serious adverse events. We're looking at each year in the USA, maybe 2 million serious ones. That's equivalent to, you just divide by 10 in terms of Canada, very significant. Hospitalized children, a large number, and in particular, and this is a number actually from our pediatric oncology wards at BC Children's, where about a quarter of the admissions to BC Children's Hospital are not due to the cancer itself, but rather the side effect of the treatment of the cancer. So this is a major issue. And furthermore, it's still the fact that that the frequency of serious adverse events, even with approved drugs where we know, and they have been phase 3, sometimes large phase 3 clinical trials, these are, the number of serious adverse events are very high. When you look in the Vancouver region, what you see, and this is actually looking, this is Globe and Mail, Vancouver Sun, about 12%, this is our major hospital, Vancouver General Hospital, in the emergency room recognized as obvious adverse events, 12%. So, and that's probably an underestimate in terms of the number of patients who are coming there where this is not recognized as this is a problem. So we recognize this, it's not particularly new, but rather adopted a national approach, as we've done before with some other issues. This week is just the anniversary of the 50th bioinformatics workshop, which is again started in the late 90s, the Canadian Genetic Disease Network. I see Brenda Galley's here, but we took a similar solution here, which was said, how can we, within the whole country, from coast to coast and sea to sea, really adapt an approach that allows us to identify individuals with adverse events across the country. And we wanted to identify, we started off with those who are most disenfranchised, those for whom often they're not tablets in the right dosage forms, and so people are breaking to get the right tablet in the right dosage form. So children with ADRs, we wanted to make sure that we got matched children on the same medications. Then we wanted to look at whole genome approaches in screening genes, validate these markers through in vitro, in vivo assessments, and then go back from there and develop appropriate dosing guidelines in an effort to predict safety. And this is really just a progress report on this particular study that has now been going on for some time. And this is the kind of networks that have been established. We're based in Vancouver, but you can see these are active surveillance sites across the country where there is somebody working for CPNDS, essentially mostly in the emergency rooms of these places or the hospitals, full-time, essentially identifying these individuals who have active ADRs that can be ascribed to a particular medication, agnostic to the drug that's causing it, and then they're spending detailed analysis, phenotypic data that is extremely detailed. Often it'll take a full day to fill this in for a particular individual, including different environmental factors, We're also very tied in with the Pediatric Oncology Network that is across the country. And we have now extended this to the adult population, and I won't be talking a lot about that, but that's mostly in Toronto and Vancouver, where we now have also support for ascertaining some of these adverse events in the adult population. These are selected. And what we've targeted, we didn't come in with any particular adverse event we wanted to target. What we said is, which are those that are really jumping out at us? Where are there sufficient numbers that we can look across the country? And so for the first 2.5 years, we just started collecting this particular data. And these were the surveillance people who are doing it, MDs, nurses, and pharmacists. These are the kind of data, medication dosages, ancestry data, detailed environmental. And we've got about 90, greater than pretty much everybody is approached, has become enrolled in this particular study, and it's a large number. So we're now more than 50,000. These are 50,000 essentially ADR cases, or including drug match controls. So this was up to March. We're now close to 6,000. We're now closer to 44,000. So it's about 50,000 individuals who are part of this particular study, and ascertainment continues, now also including adult patients, around targeted specific adverse events. And when you look at this, we've started then defining, these are some of the issues that immediately came forth in this particular group, which were children suffering some of the serious side effects of cancer chemotherapy. And these were children, of course, who had survived, and 40% of the cancer survivors have a severe ADR, so these are children who are benefiting from the incredible advances in cancer, but large numbers of them are suffering from serious, long-term, chronic adverse events. And the first drug that really jumped out to us was cisplatin. It's used around 1 million prescriptions a year to individual patients each year in North America, very frequently used in Canada, and particularly for CNS tumors, hepatoneuroblastima, osteosarcoma, and of course very commonly used also in adults. And we knew that in cisplatin, one of the big issues was really cisplatin-induced ototoxicity. We had done, as part of the frequency of this, we actually had looked at this, and we were able to show that this, the lifetime cost for an individual, just the medical, this isn't including the loss in terms of participating in school activities and others, just the actual medical cost for that individual is about 400 to 500,000. We know in Canada, if we were to institute screening for this, this would save about 20 million, around 2 million in British Columbia. And the risk of severe bilateral hearing loss, very common, particularly in children, close to half the children, and also common in adults. And so we essentially then got involved in detailed clinical phenotyping. Which way are we going here? So this is how we were phenotyping this particular population. And we were able, because of the numbers we had, to look at a normal hearing. That was very important. All the children have audiograms, and then we can compare this to people in grade 3 and 4, severe hearing loss or true deafness. This deafness is requiring a cochlear implant, or this is requiring intervention with a hearing aid in an effort to really clearly have specific groups. And our initial approach to looking at this was initially Candida gene approach. We've now gone whole genome, but when we started, we essentially started with a panel that was significant, developed with the cooperation of Michael Phillips, started off with about 315 genes. We looked at a very significant, around initially 4,000 or so SNPs, 4,600, and we've gone on to look at some of these known genes known to be involved in metabolism, for example, of cisplatin, and these are genes also involved in ADME, absorption, distribution, metabolism, excretion of drugs. Today we've gone back and are doing additional genome-wide association studies, but I'm not going to share, I'm just going to share the initial data with you. And the approach that we took was to look in Vancouver, use Vancouver and British Columbia as the discovery cohort, and then move back to look to the rest of the country for replication. And we've continued to do this, independent cohorts collected, and we were able to get very significant ascertainment in British Columbia. And this was the first report where we showed that there were genetic variants that conferred very significant odds ratios. These were very significant. These were in the 15s or so, particularly for TPMT, highly significant, and also COMT. So this was, and this is now, we've gone on from there to do additional studies, also to sequence these particular genes. And again, what we've seen is that some of these actual sequence changes are actually truly loss of activity alleles that are associated with this. And you can see this shows you that it's truly loss of activity of TPMT that's associated. And we're now doing a lot of in vitro studies to define the actual mechanism in terms of what accumulates, how does it actually cause death in various in vitro cochlear cell assays and also cell culture experiments. We've gone on also to replicate this. This is very important. So we then took, this was studies that finished about a year and a half, 2 years ago, and then independently ascertain an additional cohort. And this cohort was again from the same group because the patients are coming in all the time. This was a much more focused study now where we said we're only going to look at actually the top 10 genes in our initial screen. And these again grade 2 to 4, a smaller number of control patients. And we were able to replicate this particular finding. These were the 6 genes that we looked at initially, and a few more were added as we did that particular analysis. And what you can see here, that even though the odds ratio comes down, these are really replicated in the cohort. This is a smaller study initially for the controls, and initially was smaller. But generally, this is essentially replicates complete replication of this particular study. And when we go on further and we looked at this, we also realized that there were additional genes that could be added. And we're able now to take the combined study and put them together and actually grade them and develop an algorithm that allows us to predict the likelihood of hearing loss if a child carries any one of variants in these genes. And we're able to show, if you look at this group, you're able to predict with high certainty post-cisplatin therapy. You can see here 80% initially, and within some years up to 95%. And you're able to indicate those children that are high risk, intermediate, or low risk. And if you do carry this and you look over time consecutively, you're able to actually have a greater than 95% chance of predicting that those children will eventually become deaf if they have certain numbers of these variants. And so this becomes a very highly predictive test. We're now taking this. What's very interesting when we've gone into adults, we're doing this in collaboration with Karen Gelman and others around the country. What's been very interesting, firstly, is that adults in Vancouver are not routinely given audiograms post cisplatin and other chemotherapy that may induce hearing loss. And so when we had to go back and actually do that compared to before, and we chose testicular cancer, 1/4 of all the adults, without even recognize it, actually had significant hearing loss associated with it. And now they were in the 40s, and they thought this was just part of becoming into your 40s post-successful treatment for testicular cancer. So we're actually reassessing this. The initial data suggests that the TPMT variants are also highly significant in this particular adult population. So we're also involved in other studies. So what do you do with this information? Well, there are many things that we're actually looking at. One of them is a predictive strategy. If you know that you carry these particular mutations, you in fact can be, and we're now doing a trial of sodium thiosulfate and stratifying individuals, or they're not selecting and just looking at the whole group in an effort to see where this could in fact prevent cisplatin toxicity. Certainly in those individuals, much higher monitoring. Also modifying cisplatin dose, although there are some issues of making sure that you still are able to affect the cancer. And there are also some alternative medications, albeit they're more expensive, that really offers significant opportunities in terms of reducing this particular burden. What is interesting is as a result of these studies and two published studies now, the FDA has changed their guidelines and asked for pharmacogenomic changes. This was just in December 2011 to the FDA-approved cisplatin, including safety updates for hearing loss in children. And so this went through the review, and the FDA felt that it was time to issue some guidelines around cisplatin use in children. The next drug that we came up for us was anthracyclines. And anthracyclines, as you well know, very common. In fact, anthracyclines in terms of childhood cancer have played a major role in improvement survival, administered to 60 to 7% of all childhood cancer patients. and again in adults, also used frequently, and large numbers of patients receiving it. It's highly effective associated in terms of this therapy. But the terrible part of this is that there is a large number, 16 to 20% of patients, who develop irreversible cardiac problems. And these cardiomyopathy, heart failure, it occurs at doses that can be relatively low dose. And when this happens, and if they go into severe heart failure, they're either going to die or they'll need a heart transplant or a ventricular assist device. So it's very severe, particularly in the most vulnerable, which is less than 4 years. The mortality rate, 72% for the severe cases out from the BC Cancer Registry. So this is a very, very significant problem. And again, we did the same stratification. We could look at patients who had no cardiac toxicity, and then look at those who had an ejection fraction less than 40%, less than 20%, and able to stratify them in this particular way. And we took them through the same genotypic analysis across the country. And again, using Vancouver, we had larger numbers now, discovery and replication across the country, and also with controls. And again, what you see here is a very significant 0.29. So the odds ratio is protective. There's something about a loss of activity of this particular allele, this particular gene, which is SLC28A3, where this gene is responsible for the influx of anthracycline into the cardiomyocyte. And these particular SNPs are, in fact, loss-of-function SNPs. And so when you have them, you're actually protected. Replication was also quite significant, and so the odds ratio is highly significant and multiple correcting associated with this. And this was just published in the Journal of Clinical Oncology. We did initially in a discovery, a Canada replication cohort. We then replicated this in a smaller cohort from the Netherlands, and the combined data also stands out for that as a means to identify these particular individuals who are likely to suffer from this particular side effect. Now, this particular sodium-coupled nucleoside transporter, it's critical. It plays a critical role in anthracycline transport. It's expressed particularly in the heart. And this particular allele is a protective allele that we looked at with reduced RNA expression. And so the hypothesis we have that we're now testing in vitro, looking also at potential fibroblasts, and actually from patients who have this, and through creating in vitro differentiation into cardiomyocytes, looking at reduced and trying to look and prove that this is associated with reduced anthracycline uptake and reduced generation of some of these toxic metabolites. So this work is ongoing in our labs. But interestingly, you are now able to identify individuals, and if you identify, about 40% of them will essentially have very severe and go into heart failure within the first 6 months. Anthracycline cardiotoxicity can have a it can be quite a long-term effect, but importantly here, about half the patients you can identify as low risk, which means they have almost no chance of developing anthracycline cardiotoxicity. And that, again, changes the management profile in terms of patients, regular follow-up, how you'd follow them up. This is a big difference. And so when you look at this, we're able to use these models now. If you look at this is the risk. It's not like cisplatin, but if you look at the predictive model and you have that particular allele, and in fact, you're able to identify 75% of children who will develop cardiotoxicity compared to 4% in the low group. So again, quite protective of this, and again, we're now looking at ways to stratify treatment through low risk, just an echocardiogram, high risk, obviously alternative medication, thinking and looking at ways, and these are studies that are ongoing now, clinical trials in terms of added various cardioprotectants, and also stratifying individuals based on some of these particular studies. So let me go on to, which is mostly a Toronto story, and this is the codeine story. And you've probably heard about this from Gideon Coren, and this has been part of the CPNDS, and you know in Canada in particular, the terrible burden of oxycodone overuse associated, and the terrible morbidity and mortality associated with this. And this is certainly a very highly consumed opiate. Until very recently, 2005, the American Academy of Pediatrics said there's no problem. Breastfeeding mothers can feed, can essentially go on with normal breastfeeding. And it all changed with this Toronto mother. This was a mother who was given Tylenol, and she had some significant drowsiness. and the infant had poor feeding, and unfortunately the infant died. The mother had kept the milk of this, and this contained very, very significant high levels of morphine, and the infant's blood had lethal levels of morphine. And this raised the question about why was it that this particular mother suffered from this particular problem. And in fact, what happened is that she had both two particular reasons. She had a CYP2D6 gene duplication, and she also had this allele here on UGT2B7, and both of these resulted in the rapid metabolism of morphine to an active metabolite here, morphine 6-glucuronide, and essentially in the liver and transpose into the CNS, resulting in changes in respiration and drowsiness. And this is really the outcome. And so we went on to actually look for this in other children. This was a case control validation study looking at the pharmacogenomics of this in mothers who were just drowsy. We said if a mother is severely drowsy, what's the likelihood that she would be a carrier of this particular genotype? And here are the numbers. Here's the case. These were ultrametabolizers, about 17.8%. This was 8%. And so these were infants that eventually suffered severe neonatal toxicity. They had both of these. But mothers were close to 20%. So this didn't explain it. This was not satisfactory because, in fact, 80% of cases of codeine-induced CNS depression remained unexplained. So we went on to embark on a study that has just finished and just been published, looking for additional genetic variants for codeine-induced CNS depression. The goal was to identify these. We had a case control study. We had 111 breastfeeding mothers using codeine, and we also had, with no particular drowsiness, we also had 25 infants where the infants themselves had evidence for some depression, and we were able to look at these individuals. And we chose, again, a candidate gene approach. We were most interested in those genes that were critical, known to be critical in morphine metabolism. And so these were some of the genes that we were looked at, CYP2D6, as you've seen there, UGT2B7, and in particular here, ABCB1, which is a transporter of morphine out of the cell, and we looked at various polymorphisms in this. We only chose variants that had functional effect, and we looked for frequent variants in the general population. And we were able to show, when we looked at this, that this particular gene, the ABCB1, in fact, gave an odds ratio, small numbers in the patients, odds ratio that was significant. It's a low activity genotype, so what happened is that morphine was, you expect morphine not to be transferred out of the cell, and in combination with this was significant. And together now, this accounted for close to 60% of cases. So we've increased the ascertainment significantly, and the specificity now was in fact dramatically increased associated with this. So this was, again, an improvement. And a result of some of these studies, again, this has been followed very closely. The FDA issued guidelines in 2007, around after the first case. Again, Health Canada passed this in 2008. And the story has continued. Just this year, just a few months ago, there were additional studies, 2009, 2010, a big debate about codeine use. And this is the studies here, April 2012. The headline in the Globe and Mail was codeine deaths uncovered, and this is all relating to children post-tonsillectomy who actually had this and again suffered with codeine with severe, actually these children died. And this was a small case report of 2 children. We're now involved in and Gideon is leading this particular trial. This is a randomized controlled trial where we have 300 people of standard care. These are people who are being screened for predictive variants. If they have a positive test, they do not receive codeine. If they have a negative test, they receive codeine. This is a group that receives codeine and then retrospective, and these are the outcome measures. And of course, the question is, we won't be able to randomize clinical trials to prove the efficacy of a particular genotype for all, but this is actually close to completion, about another 6 months, and we'll be able to look at the results of this study in an effort to determine its significance. So what about clinical implementation of some of these particular issues? How do we get by through some of the barriers that we've spoken about in terms of translation of these into the community? So we are now implementing approaches to screening for children. Every child in British Columbia who's going to be getting cisplatin and anthracycline we've now implemented pharmacogenetic testing for these children. And this is at BC Children's Hospital, and we're fortunate within this particular healthcare system to have this is only administered through 6 cancer centers across BC, and so we're able to work in collaboration with the Children's Hospital lab, and essentially we're looking at these children, monitoring them, and then working with the families, not around a particular course of action, but working with those families to determine what is the appropriate course of action that the families want to take in light of the evidence that we have. And so we have some current evidence. We want to get input from the patients and families, clinicians and research. We're developing these clinical guidelines. We're looking for new evidence, particularly around the families in their communities. What does it mean? How should this profile be altered? We're also working with other researchers. And the goal here is to come up with clinical practice guidelines that are relevant for the community, able to be delivered through cancer centers, and that are relatively cost effective. So the clinician scientists are leading this. We're working with clinical treatment teams, discussing the treatment options for individualized therapies, and also with an accredited lab for the genetic testing. Now, you might say, well, this is very interesting, but as global citizens, what relevance does this have to communities outside of Canada? And I've been very interested in this, in particular in the African continent. And so we've gone ahead just to look within the African context to ask ourselves, how frequent are some of these variant alleles in the African population, just in the general population, and what might that predict in terms of ototoxicity and anthracycline? These are World Health Organization recommended medicines, and so they're used throughout Africa. There is no way to detect deafness. Children just drop out of school. Mother then stops working, and a lot of this leads to deterioration and massive impoverishment of the family. Cisplatin is widely used throughout in the treatment of solid tumors. It's one of the World Health Organization essential medicines. And so we just asked a simple question. There already was data out there. For example, if you look at the African American population, you look at cisplatin ototoxicity. This is looking at nephrotoxicity and looking in the adult population, thought to be around 50%. And in fact, in South Africa, increased cisplatin toxicity. And also, it seems that in the South African population, they do not tolerate the cisplatin doses that would be recommended in Caucasian population. So we were most interested to look at this. And this is just looking at the first evidence, unpublished data from different African populations, Yoruban, Sararan, West and East African. And what you can see here, if you look at some of these particular alleles, much higher frequency, 42%, 42%. And if you look at some of these in different parts of Africa and you compare these, and again, these are significantly increased on what we're seeing compared to the European population. So this would suggest to us within the African context, and the same is true for the essentially SLA, the transporter and the alleles associated with the transporter in the anthracycline group. Again, suggesting that the African population as a whole, but showing some differences between them, also is at very significantly increased risk for some of these adverse events. And the challenge is, how do we make sure that the benefits of these particular advances are not only here, but also distributed widely? Anthracyclines here, 16%. This is known toxicity, essentially, and this is 7% versus 2.4%. This is in the adult Caucasian population. And if you just look here, this is just some early data from European ancestry, 15%, 2.5%. Again, significantly increased risk relative to some of the anthracycline alleles that we've just spoken about. So I think this gives us a perspective that as we think about this personalized medicine, it's not just relevant for the developing world, but the developed too. We need to have an allele frequency data for all populations, and black is not black. Many times within the black population, they're more genetically divergent than between blacks and many other ethnic ancestries. In Cameroon, for example, depending on what region of Cameroon you were, we saw grossly divergent allele frequencies. And in fact, this may account for some increase in toxicity. And now what we need to do is really identify some of these cases and go out and see whether we can truly identify these patients and start mobilizing ways to try and reduce what could be a very significant morbidity in other populations. So the phenotype is very important, adequately phenotyping. We do believe that certainly that there's the whole genome sequencing, certainly for pharmacogenomics, and using, for example, ways in vitro to determine and differentiate even fibroblasts into the appropriate cell type in an effort to determine the functionality of an allele on that. So you take a fibroblast from that particular patient who has that particular side effect. Of course, we believe that through ADR prevention, and hopefully in the long term, this is going to lead to increased medication safety and represent the hope for the personalized genetic revolution. Now, this particular study that we're talking about is co-led by myself and Bruce Carlton. It's got people across the country that are playing a major role in this, and I want to thank you for your attention.
We have time for some questions.
We know enough about the structure and the mechanism of some of these enzymes that you can take related drugs and be able to predict how they would behave in some of this?
Yes, I think there are certainly some common mechanisms around each of these, many drugs being used. And one could predict that some other drugs from a particular class would also be expected to have particular side effects. So it all depends also on the metabolism of that particular drug, and we've often seen drugs from a particular class that really have altered PK, altered levels in plasma, altered distribution, altered pharmacodynamic effects. So whilst one could predict that, I think what's needed are studies to be absolutely sure. And then occasionally, because it's sometimes cell type specific and needing absorption into that particular cell through the cell membrane. Sometimes that particular drug with just a different hydrophobicity or different alteration may not get into the cell. You may find that those are actually truly safe. So when you predict, but and mostly that's true, but not always. Yeah.
Thank you very much for that wonderful talk.